everyone. This is Megan Antonelli. Today, we're tackling one of healthcare's most persistent challenges. Nearly half of American adults have hypertension, yet control rates remain stubbornly low. My guest, Dr. Andrew Davis, professor and clinical quality expert of University of Chicago Medicine, and clinical pharmacist, Dr. Amy Wainwright, analyzed over 37,000 patients across 112 providers using a machine learning platform to uncover critical gaps in medication utilization and care coordination. Then they developed targeted interventions to address them. Today, we're going to hear about that study and the interventions that they used. Hi, Andy. How are you? Hi, Amy. Welcome.
Oh, great to join you.
Great to be here.
So glad you could join us and really excited about this. You know, we work with the American Heart Association. We were there at Scientific Sessions, and congratulations on having the poster there. I am sure such a great event every year. My favorite thing about it is seeing all of the physicians so excited about the technology and innovations that are happening. I'm often on the other side at the technology conferences where we talk about how technology is a burden and it's difficult. But when I go to that one, I always feel like they're very excited to learn about the technology. So I'd love to hear about, Andy, let's start with you, kind of your background and how you got, sort of started with this study.
Well, I'm a longtime primary care physician. I'm a general internal medicine physician and also boarded in preventive medicine. And blood pressure is a standard and challenging issue as long as we've been working on it. And the new American Heart Association hypertension guidelines gave us an opportunity to say, can we do a better job understanding who our poorly controlled blood pressure patients are? What are their comorbidities? Who has diabetes? Who has renal insufficiency? Who has heart failure? And can we feed back actionable information to the physicians who are seeing these patients with precision on their medication prescribing, their dosing, the number of classes they're prescribing? And then finally, can we link it to some of the newer Bluetooth-enabled blood pressure cuff measuring techniques that will allow us to bring in population health, clinical pharmacists to bear on the issue and really show that we're making a difference in their blood pressure control.
Yeah, that's great. Amy, how about you?
Sure. I've been a pharmacist for 21 years. I've been here at the University of Chicago for about 3.5 years, working with the primary care group, primarily with hypertension and diabetes, most specifically in our remote patient monitoring program, where we give patients Bluetooth-enabled blood pressure cuffs so that they can check their blood pressures at home. And it's tied to a protocol where nurses and pharmacists weekly outreach to the patient and can adjust medication and provide additional lifestyle education.
And Amy, can you talk a little bit about the digital navigators? As most of our patients in this day and age now have smartphones, where do the digital navigators fit in?
Sure. So we have a group of medical assistants act as digital navigators who help the patients. They help link the cuff to Epic, which is the AMR that we use, into their MyChart, as well as help patients troubleshoot if they are having issues. They do also show the patient how to use the blood pressure cuff while they're in the office so that they can have the best blood pressure accuracy at the home. And then they're also available for troubleshooting moving forward. So the patients can visit with the digital navigator anytime and get more information and some help if needed.
That's amazing. It's such an important piece of this. I mean, as we introduce new technologies and obviously how you use them, when you use them, it's critically important, especially in a research study like this. So were those already in place or have they been something that you have to sort of bring in to kind of do studies like this?
So the digital navigators is something that when we started the remote patient monitoring program for hypertension was something that Dr. Sachin Shah, who is our was kind of over this program. He saw that was a need really for patients to be able to have that additional coordination for this. So it's just part of the program as a whole, regardless if they're part of a study or if they're just part of our general population.
Got it. Now, in terms of that study, I mean, I think hypertension is such a, it's one of those invisible ailments, right? That, people, don't know until they're diagnosed, and then keeping that compliance is often hard. So, Andy, tell me a little bit about, kind of what surprised you about the baseline data as you guys were doing this research in terms of, what it reflected in terms of like the practice in chronic disease management and how we're managing those populations.
Yeah, we're on the south side of Chicago. Probably 50 or 60% of our patients with hypertension are Black ancestry. So that was not a surprise. Our board came to us and showed we had a persistent 9 and 10% gap in blood pressure control, using even a loose definition of less than 140/90, with about 67% control in our Black patients and 77% control in our white patients. And we actually made that a priority metric that we've been tracking. So we look at simple things, saying, do you repeat a blood pressure in 5 minutes in case the traffic was terrible coming into the office? But what MD Clone has allowed us to do, and that's linked up through Julie Johnson and Tom Spiegel, and it's a cloud-based kiosk platform that allows us to look at big data and pull in lots of things at the same time in a way that would just take lots of analyst time, particularly when you explore things. Each time you get a report, you have 3 or 4 more questions. And I can do those using the kiosk system in a matter of hours, as opposed to getting back in the queue for that. I think the emphasis increasingly in healthcare is looking at overall cardiovascular risk, cardiometabolic, renal health. And what's been surprising to me is, or useful to me, is understanding the context of how many classes of hypertension medicines are being prescribed. Are they being prescribed at an adequate dose? Are there contraindications, such as kidney failure or weak kidneys, in which that would affect the prescriber? And we also are bringing in adherence data. So if we see someone that perhaps is not taking their medicines using sort of all scripts feeds for refills, we have the potential then to say maybe that medicine is too expensive, or maybe there's a side effect that you haven't discussed with your primary care physician. We can look at who prescribed all the medications, and we can go back to the 23 primary care offices and the leaders in those offices and say, in these offices, you're not using enough combination medications. You're not using medicines like spironolactone, which can help in resistant hypertension. We notice that the median blood pressure and the last blood pressures have been consistently high. Would you consider a referral to the kidney doctors or to our cardiologist? So it gives us a very rapid turnaround. I get data within a few days of it posting in Epic, but then I can manipulate it with queries that are focused on a particular office, on a particular provider, bring in comorbidities, lab data, and also see if they've been referred to remote patient monitoring, where our terrific population health nurses and clinical pharmacists can also be enlisted in getting these folks under better blood pressure control.
And you mentioned the MD Clone machine learning platform. Tell me a little bit about what that is and how it has, what data is going into that? How does that interface with the systems that you currently have?
Our relationship with them, I think they're based in Sheba Hospital, which is a big research center in Israel. But they've been increasingly working in the United States with institutions like Intermountain Healthcare, Washington University. And the agility and the real-time nature has been terrific. And we can ask a question and then think of 3 more things as we get the results back, and then just slightly tweak the query and look at the answers to that. So I think it's me as a frontline physician with some health services research, but I'm not, a full-time health services researcher. I can say, gee, who has heart failure, How would that affect? Are they getting goal-directed medical therapy that would keep them out of the hospital? Because we all know heart failure is a common reason for particularly Medicare population people to be admitted. So I think it's the timeliness, the big epic tableau type of approaches are useful for getting out paper performance reports and CMS adherence, but then to say, what is it about in a given office, these three doctors are getting great control, and these folks are not getting great control. I can look at the demographics of the patients and say, this person is not prescribing as aggressively or titrating upward as rapidly. Those are the kind of questions I can find very quickly that are hard to see in the big platform kind of quality reports that we're used to.
Right. And how did the clinicians, when you give them that feedback, how is it sort of how do they respond? Are they happy, or are they like, how'd you know that?
If you make it easy to do the right thing, and there's a phrase in quality improvement which says, who's doing a terrific job in the office, and boy, we knew she was great already. What does she do differently? Oh, combination pills, but aren't they all expensive? No, this combination pill is not quite so expensive, and patients have really liked taking fewer pills, and their blood pressure control is better. So I think part of the challenge in large systems are in MD clone. I can say, has this patient actually been seen by a primary care doctor, and have they written a note on this patient in the last year? And so when we focus our reports on patients that the doc knows they've seen, as opposed to you get a report with 50 names and they say, well, I haven't seen these 13. This data is rubbish. And so I think the ability to say, yes, you've seen them. Yes, you've coded for hypertension, and you're not getting quite as good control as someone you also respect in your office. And here's some of the things they're doing a little more intensively. That's looked at as helpful. So that if we can make things easier to do the right thing, if we can bring on the population health nurses and the clinical pharmacists to find affordable medications and better regimens, the patients the physicians are happy, because then their report cards for blood pressure control look better, and they haven't had to do too much thinking about it. So I think in general, people are happy if we can get accurate, timely data. If you give them a report from 6 months ago or a full year, and 20% of the patients they don't even think they belong to them, you're going to get pushback, and it's another thing to ignore in my inbox.
Right. Yeah, no, I think when I think about when we first started talking about social determinants of health and kind of all these increasing data points that we wanted to look at that would impact, better patient care and how we could improve interventions, I just remember the first obstacle was sort of, who's going to look at this data? How are we going to look at this data? How is a physician possibly going to have the time to do more? To look at more. And it just seems like with what you're talking about, not only are you allowing them, you're sort of pointing them in the right direction, but you're also then giving them that tool to, make those improvements and provide better care, which of course is why they're in this to begin with.
And Amy is, one of the most popular people. All our physicians know Amy in the in our medical group. She's a wizard, not only at hypertension, but also GLP-1s and fighting with insurance companies about GLP-1s. Amy, can you talk about, how...
Sounds like you'll be popular with my friends too.
There, I have no shortage of in-basket requests. So there's a lot of things that I think are really important that the MD clone, as Andy was really talking about it. So one of the things that we have is monthly. Because hypertension is such a big deal for our system, once a month we have a hypertension management group that we kind of discuss, at different interventions that we're working on, whether it's RPM, whether it's engaging our community health workers to help patients address, some of those social determinants of health, being able to connect to Meals on Wheels, or being able to even do a home medication reconciliation with the pharmacist and the community health worker, or even if it's just re-showing them how to use the blood pressure cuff. It's been nice with the MD clone, kind of to go back to some of the points that Annie's made, is that usually what we would do is we'd have the meeting, then the next month we would see if anything had changed. But with MD clone, we were able to, Dr. Davis was looking at that information that evening. We would get an email out with the results of, looking at it from maybe a different angle or a different qualification, how many patients are on ACEs and ARBs, and we would get that list. And then, if our team had another thing to query, he could then, modify that day or the next day. And, within a week, we would have, multiple iterations of that information, so we could better focus. And we use it as negative or positive. So, if one of our teams is having, we have an offsite clinic that has excellent blood pressure readings. And so their blood pressure control rate is very good. So that made us want to go there and see what's different.
Yeah.
What are they doing right that we're not, that we're not doing? Is it, the physical, space that's nicer, better, the free parking, those kinds of things, or, is it the prescribing? So we're able to kind of filter down into that information. Now, as a pharmacist, one of the things that's been great is being able to work with patients on making sure that they're taking their medications, understanding why they're on different medications. I also work with our population health nurses so that when they have patients that are more challenging, have a more complex regimen, helping them know kind of the next step to go to. That is, it's very protocolized, but I think sometimes it's nice to have that additional person to feedback with and to consult with. And so our pharmacist team also works with the nurses in that capacity. We also do educations with them to keep them up to date. So when the guidelines changed, we went back through that with the nursing team as well, so that we could provide that education kind of for our staff, as well as be able to share that education to our patients, so that they also understand why things are changing and why these changes to lower blood pressures are important, and that it lowers the stress on their heart and their kidneys, so they're less likely to have that heart attack or end up on dialysis.
And I want to pick up Amy's point about our hypertension task force. Rapid, timely, accurate data that you can quickly tweak and do another round is catnip for physicians and particularly research-interested physicians. So the lead author on this was Amber Johnson, who's an NHLBI-funded researcher. We've worked with Tammy Polonsky in preventive medicine. We've worked with Celeste Thomas, who's in endocrinology. So we're working with Milda Saunders, looking at the deterioration of renal function in our people having spillage of albumin into their kidneys, checked on a rapid basis. When you can get data and then modify it to the interests of your collaborators, perhaps in different departments, that's a very exciting thing, and I think adds to our momentum and sort of a sense that it's not just a silo of, well, I'll just talk about the blood pressure and never mind the diabetes or never mind the heart failure. You can pull in collaborators, you can pull in junior faculty fellows who have research interests, and as a team, you just get further, and you maintain the excitement and the momentum of your quality improvement.
Yeah. I mean, it reminds me of the days where we talk about kind of the report cards and these static sort of things. And this is much more of this interactive real time. And also I think that your point about, even when it's well, I didn't see that patient, or, they can't argue with it because it's also accurate, right? So it's real time accurate data that they relate to and they can then respond to. So you're just giving them those tools, to practice medicine better.
And some solutions too. You're saying we've got, terrific folks who can help you get there. they've missed 3 appointments. Well, we can look at no-show rates, and we can figure out if there's a community health worker that we might want to put on this case. Are there transportation issues? Are there literacy issues? Are there language barriers? And
Right.
so there are lots of we can begin to really dig down on the people that are poorly controlled and are going to be future. They're going to, not only ding us on our quality measure, but they're going to be future emergency room visits. They're going to be future hospitalizations. And that's what gets our chief financial officer interested, as if we can improve care and reduce dialysis and reduce lengths of stay in the hospital for heart failure. Then suddenly it's not, you're doing a nice science project, but it actually may have importance for the budget of the medical center.
Right. And maybe with the wins, Amy, like you mentioned, when you identify the pockets of where everything is going right, the clinicians want to take the credit for it. That often it has more to do with the environment or the situational, or the demographics of the space. Are there any, were there surprises in terms of some of those factors that led to either outstanding positive results, or on the other side, on the negative side?
I think I was surprised. I can tell you about 4,500 people with kidneys that are starting to get towards dialysis range. I can tell you the 10,000 people with heart failure, and I can also see how rarely they've been referred, or at least completed a referral to specialists. So I think those are the people that are hovering to come into your hospital to be expensive to the healthcare system, and they're out there, and often there are many other priorities in their lives other than taking medications. And if you say you're on 3 medications now, they're expensive, I can give you a combination pill that it'll make it easier and it's affordable and will help you on that. Or I can give you a little video to watch that talks about proper dietary approaches, and that's going to help you feel better and do more of the things that are more important to you than coming to a doctor. We may get more traction. So that I think in some ways it was not a surprise, but we knew we weren't doing a good job for all of our patients, and that's been an important lesson, and a bit sobering to see that. But overall, I'm pretty optimistic that docs are innately a little bit competitive. They want to do well by their patients, and if we can set up systems to help them, so it's not all on them in a very crowded 15 or 20-minute visit, and the patient comes back to them 3 months later or 6 months later, and their blood pressure is under better control, the docs begin to trust the information, and they begin to trust the process, and are somewhat grateful for that team approach, and not all on them with everything else they're having to deal with during their clinic visits.
Amy, did you have something to add to that?
Yeah, one of the things that we created as part of the RPM program was a smart set, so that even if they weren't using the RPM program, that the physicians could add in a MyChart flow sheet, so patients could upload blood pressures from home if they already have a blood pressure cuff. But it also listed some of the single pill combination medications. I felt like a lot of our team, especially because a good portion of our team are medical residents in training, and so they're not as familiar with those and what's available. And so making just some of those little changes just across the system just helps bring it a little bit more to the front of mind, front of eyes and front of mind, so that they're more likely to prescribe a combination because they see it. They're not thinking, I'm going to do a thiazide, I'm going to do an ARB, I need to do a calcium channel blocker. Well, there's actually, now you can see, there's actually a triple combination that we could put the patient on one pill. They're on 3 medications to lower their blood pressure, and we can get them under control a little bit faster. So doing some of those things has really been super helpful. We actually also did a focus group amongst our patients as to one of the reasons why they might feel that they weren't taking their blood pressure as seriously as we thought. often your physician's area of focus and you as a patient's area of focus does not always match. And so for our female patients, a lot of them, they were caregivers. And so they were more concerned about other people's health and not their own. So we've kind of reframed some of our discussions about, using the saying about, putting your mask on first before you can help somebody else. So making sure you're helping yourself and taking good care of yourself so that you can care for your grandchildren, your great grandchildren, your siblings, whoever you're helping, your neighbors. You can still go to church. And then for some of our men, it was we weren't as direct about how severe having high blood pressure is. No one told me it would kill me. It would cause it would cause me to go on dialysis. We kind of, talk about how important it is, but I think, sometimes you have to put it into their situation. Like why is it that we're after it? A lot of our male patients aren't as good, using that same mask scenario isn't necessarily going to work for them. But, do you want to be around to, help out your family? You want to keep working, all of those kinds of things, because this could really land you in the hospital, and not necessarily death, but disability could be an issue. And, being able to kind of refocus that, I thought that was very interesting when we had that information.
Fascinating. I mean, I think, and when you think about, when we talk about kind of digital transformation and how this technology can help, and here you're talking about, much more simple solutions, right? Just we're changing how we're communicating with literally the sexes, male versus female, just simple things that, we make it all generic because that's easier, but those being able to speak to what matters to them, whether it's, also the physician for changing their prescribing behavior or their treatment behavior, but also the patients, and just understanding those nuances. I mean, when you think, it's like common sense, I was just reading, I think it was Shaston Jain's article on common sense, just practice medicine better, but we need the data to do it. Right.
And one other thing I'll throw out, the chief of our general internal medicine is a health services researcher named Nita Latirapong, and she's done a lot of work in younger patients that are developing diabetes, even type 2 diabetes in their late 20s, 30s, and we're seeing an awful lot of people, 25, 35, 45, who are feeling pretty good because they're relatively young, but their risk factors are off the chart. And Dr. Latirapong's research has said if you can get to people in the first year or two of their diabetes and control them well, they don't tend to get the long-term complications that we're so used to. And so a lot of the pay for performance things are, look at your 50s and 60 and 70-year-olds. The horse is out of the barn. A lot of times the damage to the vascular system and the kidneys have already been done. And so Dr. Latirapong and Dr. Celeste Thomas are also focusing on these younger age ranges. They're, late 20s, 30s, who are going to be your admissions or going to be your complications, but we're getting to them hopefully 10 or 15 years before they have terribly swollen legs and can't breathe and have lungs full of fluid. So I think that's another exciting area that we're looking, where you can identify these subsets. And that's, we were talking about men and women, but I think younger folks also, there may be different communication styles, different, certainly more digitally savvy. And so we open the opportunity to do tailoring, not only by age, gender, race, socioeconomic literacy, language, but also just age. And that's been a bit of a surprise for me, and I think has really opened up the opportunity, because that holds the promise of, keeping people from ever getting into trouble at all, rather than fixing them after they already have multiple complications.
Right. Which is, that's what it's all about, right? I mean, I think every conference, every, sort of thing that you read about healthcare. It's all about how are we going to change from the sick care to a true healthcare system where we're actually managing people's health, extending their, well span and all of that. And I think this seems like a solution moving in that direction, which is exciting. When it comes to, you mentioned the CFO and what the CFO wants to see, a little bit around, I've been hearing as we've kind of gotten into maybe year 2 or 3 of some of the implementation of these AI and machine learning solutions, where you see the value, where you see the ROI. What are some of the key metrics that, sort of the organization, the administration side on the hospital is looking at with these tools, and where are they seeing the value?
I think initially we've sort of gotten our arms around the technology and see what it can do on audit and feedback type of things. In the near term stuff, though, the University of Chicago is a leading transplant center, and part of the reimbursement for transplants is if you have a robust waiting list for people who have been thoroughly vetted, and hopefully we're going to keep people from getting to the point of needing transplant. But we've found a lot of people who are, the kidneys are quite weak, but they haven't had appropriate dietary counseling. They're not on the proper medicines. They're not watching their potassium in their foods, for instance. And if we can build that and connect to the proactive renal management, that's one thing. Another thing we're also finding is patients with heart failure who are not taking the 4 classes of medications that are useful, and in some cases are appropriate for cardiac procedures that are well reimbursed. Like say someone with atrial fibrillation, irregular heart rate, and they have a poor ejection fraction. Their quality of life and their mortality is better if we identify them and then we put them in the hands of the right interventional cardiologist, which again tends to be a more remunerative thing for the health system. So those are some of the, and then of course the big things of length of stay, readmissions. There's also reputational thing. If we can show that we're doing an excellent job relative to other academic medical centers, that builds referrals, that builds trust, and that's something that institutions care about right now. So I think there is MD Clone increasingly is building out ROI tools and dashboards to help the managers kind of see what projects are underway, which of them can we connect to, and clear needs that also have financial implications. And so the MD Clone has been pretty smart about sort of building that in. But we're in that rollout period right now where we're beginning to link to financial outcomes. The docs want to do the right thing. You have to have a margin if you're a medical center. And I think increasingly doctors are seeing and administrators are seeing that they can work together and have a mutual benefit.
Yeah, no, that's amazing. And I think the value just in being able to kind of, that real-time clinical analytics to get that to the physicians, is so important to the patients because they can act on it.
Yeah.
And, in our last few minutes, we always like to close on the, what are you most excited about in healthcare? And kind of, all of this is so exciting. So, Amy, maybe we'll hear from you on what you're excited about, and then we can close with you, Anne.
Well, since I was outed as the GLP-1 coordinator, I am very excited that I believe that 2026 will show us some additional GLP-1 agents availability, as well as potential expansion into Medicare and Medicaid coverage, which would be huge for our patients. Especially on the Medicaid side for some of that prevention. If our program, as a side, we also work with children with and their metabolic weight loss, and so being able to get somebody maybe as a young adult not to reverse their hypertension. Reverse some of obesity, that would be amazing. So, we do have some patients that cross over between our weight loss and our blood pressure, and we're seeing some of those patients come off of their blood pressure medicines, which has also been exciting.
Yeah, we're hearing that more and more for sure. How
And
about you, Andy?
yeah, I think to me, having the, if you will, the content experts, in other words, the clinicians that are cared passionately about blood pressure or diabetes or kidney disease, be able to look at large databases. If you're a person managing your IT department and the physicians say, we want these 16 things, with MD Clone, I can actually say probably only 5 of those things really count. And those are the things that our analysts might then put onto a platform and monitor more on a system level. But you get the agility of the content experts, the physicians, without having tons of IT training themselves, to be able to ask the questions and say, okay, we don't need 16. We're not going to drive your analysts nuts with, oh, can you get us this, and can you get us this, and can you get us that? And we can do the preliminary work and then come to the ID department and say, this is strong enough that we actually want to build in the standard reports around it, because we've shown that it has leverage in our patient population. So I think that marriage of content experts with the more analytic ability, and then that works hand in hand, that your analysts and your IT department aren't chasing will-o'-the-wisp things, which we didn't really need those 16. Sorry about all those other things we asked you to get. I can do some of that preparatory work and get us hopefully more in line with certifications from the American Heart Association, or building practices that are going to have financial implications for the institution, without driving your analysts nuts with week after week. And we've got to get to another project, but I've got 3 more questions. And so that's where the kiosk-based platform, I think, has been a revelation to me. And I think we're going to see more and more value as we get more experience with it.
Yeah, no, that's super exciting. I think that promise of being able to really kind of translate the data into provider level action and prioritize, right? I mean, we're always sort of suffering from this shiny object syndrome in healthcare, where we're going after the next best thing, and to be able to, one, know in advance that it's going to have impact, but to identify it and then to see the impact happen is so amazing. So, yeah. Well, thank you both for joining us today. I could learn about this and hear about it all day, because it's just exciting to see, these programs and platforms in action, and how they start from where they are all the way to, really touching the patient and changing how the clinicians and the community are working together to take care of these patients. So thanks, everybody. Thank you, Dr. Andrew Davis and Amy Wainwright, for joining us and for sharing the University of Chicago Medicine's experience. For healthcare technology leaders working on population health analytics, quality improvement initiatives, or care coordination challenges, this conversation offers practical insights on turning EHR data into clinical impact. I'm Megan Antonelli with Digital Health Talks, and until next time, we'll see you then. Bye.